Good morning, everyone. Thank you, Dr. Guan, Dr. Yus, for the introduction. My name is Patrick Jovan Gagno. I'm a general surgeon from the Philippines and a recent graduate from the University of Edinburgh. Thank you, SAGES, for this opportunity to present our work entitled Variation of Venous Thromboembolism Prophylaxis Use in Emergency Abdominal Surgeries Between Low, Middle, and High-Income Countries, a multi-center international prospective cohort study. Oh. I have no conflicts of interest that requires disclosure. 7. Just a brief background, venous thromboembolism is considered a major cause of postoperative morbidity and mortality in emergency operations. And focusing on emergency general surgery procedures, approximately 2.5% of patients develop deep vein thrombosis and pulmonary embolism. And optimal guidelines-directed VT prophylaxis is considered one of the best practice for enhancing morbidity and mortality outcomes. But despite this recognition, worldwide compliance of VT prophylaxis in emergency surgical settings is poorly described in the literature. The primary aim of our study was to determine the global variation in VTE prescriptions among patients who undergone emergency abdominal surgeries in low and middle income countries, and we sought to examine its potential association or correlation with mortality and postoperative complications, complications. So our study was a subgroup analysis of the Global Search 1 project, which is which investigated the mortality of emergency abdominal surgery patients in low and middle income countries. And this data was collected by participating hospitals, which comprise of approximately 3 investigators in 2-week intervals between July to December 2014. And these data were then collected and put together into a central database using REDCap. And our patients who undergone emergency, all patients undergone emergency intra-abdominal surgeries, either lap, open, or lap converted to open, regardless of age, were included in the analysis. And patients with elective surgeries and with cesarean sections were excluded from the analysis. Our primary outcome was the reported use of venous thromboembolism prophylaxis, which is documented as drug-only, mechanical-only, combination of drug and mechanical, and others. And our secondary outcomes were 30-day mortality and major and minor postoperative complications. And postoperative complications were categorized by the Clavien-Dindu classification, and class 3 and 4 were considered as major complications, and class 1 and 2 were minor complications. And multivariable logistic regression models were created to analyze the data, and where effect estimates reported as odds ratios in 95% confidence interval. Our data are approximately 10,733 patients underwent emergency abdominal surgeries from 357 hospitals in 58 countries were included in the final analysis. And this graph shows the percentage of patients who were prescribed with VTE prophylaxis, where approximately only 14% of patients from low-income countries and 21 patients from middle-income countries were prescribed VTE prophylaxis, compared to 78% of patients from high-income countries. According to the type of VTE prophylaxis, we noted that combination drug and mechanical VTE prophylaxis were mostly prescribed in high-income countries, but drug-only prophylaxis were more prescribed in low and middle-income countries. And VTE prescription is also, we also noted that VTE prescription is increased in patients with advanced age, female gender, smokers, and with higher ASA grades, and procedures such as laparoscopic approach, bowel resection, and the use of surgical safety checklist. Based on our multivariable logistic regression results, our analysis noted a decrease in the odds of venous thromboembolism prophylaxis in low and middle income countries compared to high income countries. And this plot shows our results for the multivariable logistic regression of our secondary outcomes. And we noted that there is no difference in the 30-day mortality in patients who undergone or prescribed with VTE prophylaxis versus those who did not receive one. However, we noted an increase in the major and minor postoperative complications to those who undergone or prescribed with VTE prophylaxis compared to those who did not. For the limitations of our study, because of the descriptive nature of our study, this limits its generalizability. And we also, another limitation was there's no specification of the DVT or pulmonary embolism or either bleeding events as complications in the data, and also the VTE risk stratification was also not collected. In conclusion, our study highlights the significant decrease in VTE prophylaxis usage in emergency abdominal surgeries from low, middle, and middle income countries compared to high income countries. And because of this, the low middle income countries were priority groups to encourage compliance with guidelines directed VTE prophylaxis. And based on our limitations, future studies are encouraged to do in VTE regarding VTE events in limited resource countries to further describe variations in mortality and postoperative complications. And I'd just like to acknowledge that this research project was undertaken as part of the evidence-based surgery course requirement of the Master of Science in Surgical Science at the University of Edinburgh. Thank you.